LVAD infections, from the skin to the pump. If you take care of patients with LVADs, there is one concept that makes infections much easier to understand. LVAD infection is not one disease. A little drainage around the driveline is completely different from infection extending down the driveline tunnel. And that is completely different from infection involving the pump, the cannulas, or the bloodstream. The deeper the infection travels toward the blood-contacting components of the LVAD, the more difficult it becomes to eradicate. So today, I want to build this from the ground up. First, what exactly is inside an LVAD? Second, where can infection occur? And finally, how does the name, and more importantly the treatment, change as infection moves deeper into the system? Start with the circulation. Blood leaves the left ventricle through the inflow cannula, which is surgically positioned at the left ventricular apex. That blood enters the pump. In the HeartMate 3, this is a centrifugal flow pump using a fully magnetically levitated rotor. The pump then propels blood through the outflow graft, which is usually anastomosed to the ascending aorta. So think left ventricle, inflow cannula, pump, outflow graft, aorta. That is the blood contacting portion of the system. HeartMate 3 uses fully magnetically levitated centrifugal flow technology. HeartMate 2 and Heartware HVAD are important historically, and patients with those devices remain in clinical practice, but they are now legacy platforms rather than devices used for routine new implantation. But there is another component that is incredibly important to us in infectious diseases: the driveline. The driveline is the cable that runs from the implanted pump through the subcutaneous tissues and then penetrates the skin, usually somewhere on the abdomen. Outside the body, it connects to the controller and the power source. And that creates the fundamental infectious problem with an LVAD. There is a permanent communication between an implanted foreign body and the external environment. That skin penetration point is the driveline exit site, and it is the most common portal of entry for VAD-specific infection. Now look at the anatomy another way. There are essentially several levels an infection can involve. You can have infection limited to the skin around the driveline. It can extend deeper along the subcutaneous driveline tract. It can reach the tissues surrounding the pump pocket, or pump-associated space. It can involve the pump itself, or the inflow or outflow cannulas. Or organisms can enter the bloodstream and produce bacteremia or endovascular infection. And once you understand that progression, the entire treatment strategy starts to make sense. There is an important epidemiologic paradox here. The most common infections are the least deep. In the major international registry analysis, among VAD-specific infections, approximately 83% involve the driveline, 13% the pump pocket, and only about 4% the pump or cannulas. So driveline infection dominates numerically, but pump and cannula involvement is much more serious. That gives us a useful teaching principle. Frequency decreases as you travel inward, but clinical severity increases. Now, how do we classify these infections? Traditionally, the ISHLT framework divided them into three major conceptual groups. First are VAD-specific infections. These are infections that essentially exist because the patient has the device. Driveline infection, pump-associated or pocket infection, and cannula infection. Second are VAD-related infections. These can occur in patients without an LVAD, but the presence of the device changes their epidemiology, consequences, or management. Examples include bloodstream infection, infective endocarditis, and mediastinitis. 3. Non-VAD infections: pneumonia, urinary tract infection, C. difficile infection, gastroenteritis, and so forth. The 2024 ISHLT definitions updated and simplified this terminology, particularly for percutaneous driveline and cannula infections. emphasizing clinically meaningful distinctions such as uncomplicated versus complicated infection, rather than relying only on the older location-based terminology. But for bedside teaching, I still find the anatomy extremely useful. So let's walk from the outside inward. Superficial driveline exit site infection. Imagine the patient comes to clinic with erythema or drainage directly around the driveline exit site. No abscess, no clear deep tract involvement, no bacteremia, no systemic toxicity. This represents the superficial end of the spectrum. The first step is microbiology. Culture any purulent or significant exit site drainage and obtain blood cultures when systemic or deeper infection is suspected, ideally before antibiotics when clinically feasible. Then treat according to the organism and susceptibility profile. Because staphylococci dominate the microbiology of these infections, empiric therapy frequently needs gram-positive coverage initially, but the goal is always to narrow therapy once cultures return. For a genuinely uncomplicated superficial exit site infection, the treatment may be oral and outpatient, combined with meticulous wound care and, very importantly, driveline stabilization. Duration is approximately 7 to 14 days as a practical teaching range for uncomplicated superficial disease, although actual duration should depend on clinical response, organism, and evidence of deeper extension. And that last point matters. The bedside exam matters. Because if there is persistent drainage, significant pain, induration, systemic symptoms, bacteremia, or evidence that infection tracks proximally along the driveline, we are no longer talking about a simple exit site infection. Deep driveline infection. Now infection has moved down the subcutaneous tunnel. This patient may have fever. They may have increasing pain along the driveline tract. There may be fluctuance, abscess formation, deep drainage, or systemic symptoms. And now oral antibiotics alone are usually not enough. This patient needs evaluation for deeper extension and frequently hospitalization with IV antibiotics. Culture the drainage. Obtain blood cultures. Image the tract and the pump-associated tissues when indicated. And look specifically for a collection that requires drainage. Because once an abscess exists, antibiotics cannot substitute for source control. Treatment can include percutaneous drainage, operative debridement, negative pressure wound therapy or VAC therapy, and in difficult recurrent cases, surgical driveline relocation. Antimicrobial therapy becomes prolonged, usually measured in weeks rather than days. And deep device infection may ultimately require chronic suppressive therapy because infected hardware remains in the patient. Current ISHLT guidance supports prolonged, systemic pathogen-directed therapy for significant deep device infection, with long-term suppression often considered when definitive source removal is impossible. And this is where LVAD infections become fundamentally different from ordinary soft tissue infections. Normally, when foreign material is infected, we want to remove it. But you cannot casually remove an LVAD. The pump is keeping the patient alive. Pump pocket or pump-associated infection. Now we have progressed one level deeper. The infection involves the space surrounding the pump or deeper pump-associated tissues. These patients may present with persistent pain, drainage, fever, bacteremia, or sepsis. The diagnostic principle is the same: cultures plus definition of anatomic extent. But the treatment intensity increases dramatically. Now we are talking about directed IV antibiotics plus surgical source control whenever feasible. Drain the collection, debride infected tissue, use VAC therapy when appropriate, and recognize that recurrence is common because the pump itself remains implanted. This is exactly why chronic antimicrobial suppression becomes so important in selected patients. The goal may no longer be simple textbook eradication. Sometimes the realistic objective is control of infection while preserving a life-sustaining device. Pump or cannula infection. Now we are entering the most concerning VAD-specific territory. If the pump, inflow cannula, or outflow graft becomes infected, the process is essentially a deep device-associated endovascular infection. These patients may have persistent or relapsing bloodstream infection despite appropriate antibiotics. They may develop septic embolic phenomena. They may have recurrent bacteremia with the same organism after apparently adequate treatment. At this point, antibiotics alone may suppress the infection, but achieving a true microbiologic cure becomes extremely difficult while infected hardware remains in place. Treatment generally requires prolonged pathogen-directed IV therapy, and definitive management may require device exchange or heart transplantation in an appropriate candidate. That is the critical escalation point in this entire discussion. Skin infection can often be cured medically. Pump and cannula infection may require changing the hardware or changing the heart. Not every bloodstream infection in an LVAD patient automatically means the pump is infected. The patient can have bacteremia from another source. They can have central line infection. They can have pneumonia. They can have urinary infection. They can have mediastinitis. But once bacteremia occurs, we have to ask, has the LVAD now been secondarily seeded? That question can completely change the duration of therapy and the long-term prognosis. VAD-related bloodstream infection. For bloodstream infection, obtain multiple blood cultures and aggressively search for the source. Is it the driveline? Is there a deep collection? Is it the pump? Is it an unrelated central venous catheter? Is there endocarditis? Depending on the clinical scenario, this may require echocardiography, CT, additional vascular imaging, or advanced imaging. And if bacteremia persists or repeatedly returns with the same organism, suspicion for an infected device has to increase dramatically. VAD-related infective endocarditis. Now we have reached true endovascular disease. These patients need prolonged targeted IV antimicrobial therapy. Echocardiography, often including TEE, is part of the evaluation, although diagnosing infection around mechanical circulatory support hardware can be challenging. And if infection involves the pump or cannot be eradicated with medical therapy, device exchange or transplantation may become necessary. Mediastinitis. Mediastinitis is another VAD-related deep infection. This is not a problem solved with antibiotics alone. The core strategy is surgical debridement plus prolonged targeted antimicrobial therapy. Now look at the diagnostic algorithm that I posted online on LinkedIn. I like this figure because it begins not with the organism, but with the presentation. If the patient simply has fever or leukocytosis, first do a comprehensive examination and do not anchor immediately on the LVAD. Look for pneumonia, UTI, gastrointestinal infection, central line infection, C. difficile. Everything else these patients can develop. But if the chief complaint is drainage from the driveline, immediately examine the exit site for erythema, tenderness, purulence, trauma, or wound dehiscence, and obtain appropriate cultures. If there is persistent pain, persistent drainage, or sepsis, now think deeper. Is there a driveline tract infection? Is there an abscess? Has infection reached the pump-associated tissues? And finally, if there are persistent or relapsing positive blood cultures, septic embolic phenomena, constitutional illness, or unexplained device problems, think endovascular, pump, cannula, or infective endocarditis. That progression is exactly how I would approach these patients clinically. And there is one major diagnostic trap. Do not allow a normal CT scan or the absence of dramatic sepsis to falsely reassure you. In one cohort of confirmed LVAD infections, CT examinations were normal in 37.7% of cases, and almost 29.2% of patients with endovascular infection did not satisfy SIRS criteria. So the patient can have a serious LVAD infection without looking like classic septic shock and without a beautiful abscess lighting up on CT. That is an extremely important clinical pearl. Now let's finish with microbiology. Gram-positive organisms dominate, particularly Staphylococcus aureus and coagulase-negative staphylococci. Enterococcus is also important. Among gram-negatives, Pseudomonas deserves special attention, along with other enterobacterales and non-fermenters. And fungal infections, particularly Candida, are less common but potentially devastating. This is why cultures are so important. Do not keep somebody indefinitely on broad-spectrum vancomycin plus gram-negative coverage if microbiology gives you a clear answer. Get cultures, identify the organism, determine susceptibilities, then narrow therapy. Staphylococci, Enterococcus, Pseudomonas, other gram-negative bacilli, and Candida are all recognized pathogens in LVAD infection. So here's the way I want you to remember LVAD infection. Imagine traveling from the outside of the patient toward the bloodstream. Skin, driveline exit site, driveline tunnel, pump-associated tissues, pump or cannulas, bloodstream, and endocardial surfaces. As you travel inward, three things happen. The infection becomes harder to eradicate. Antibiotic therapy becomes longer, and the importance of surgical source control increases. At the superficial level, you may need wound care and a relatively short course of targeted oral therapy. At the deep driveline level, you are talking about IV therapy, imaging, drainage, debridement, vac therapy, and sometimes relocation. At the pump or cannula level, prolonged antimicrobial therapy and chronic suppression may be necessary, and at the most severe end, definitive cure may require device exchange or heart transplantation. One final point. These patients should not be managed by infectious diseases alone. They need the LVAD Advanced Heart Failure Team, infectious diseases, cardiac surgery when appropriate, microbiology, imaging, wound care, and careful coordination of anticoagulation around any invasive procedure. The 2023 ISHLT guidelines specifically emphasize collaboration with the durable MCS team when these patients undergo procedures. Anticoagulation interruption or bridging should be individualized rather than automatically applied to every procedure. Because with an LVAD infection, we are not simply treating bacteria. We are treating bacteria attached to a life-sustaining machine that we often cannot remove. And that is what makes these infections so challenging and so fascinating. This is Dr. Ganoni. Keep reviewing the literature, keep questioning the obvious, and I'll see you in the next ID rounds.